Cancer is a very complicated condition. We have different types of treatment we can use, and we can also combine different treatments to achieve the best outcome. The selection for different treatments of cancer depends on the location and the size of the tumor, as well as the health of the individual. Doctors have to assess everything to make sure the selected treatment can do more good than harm to the patient. No matter how good the treatment modality might be, if the patient cannot sustain it or survive it, then of course the physician would not choose that route. Let's talk about surgery first. We've already learned that surgery is an invasive medical procedure, and we have covered the general principles for nutrition care for surgery patients. As far as the cancer treatment is concerned, surgery can play different roles. Surgery can be the primary treatment for cancer, meaning the patient will only receive the surgery. Usually that's used for cancer with a very early stage diagnosis or that has a biological behavior where it doesn't spread out early on. Or surgery can be an adjuvant. This means that we will first use maybe chemotherapy to shrink the size of the tumor and then perform the surgery. We can also consider chemotherapy in this case as a primer treatment, basically to prepare it, to make the tumor easier to be removed by surgery, because if the size of the tumor shrinks after chemotherapy, that means the surgery may be less invasive. Surgery can also be part of combination therapy. For example, we may do the surgery first and then complete the radiation or chemotherapy later on. So this is the main difference between these two treatment strategies, the adjuvant versus the combination. Do we do the surgery first or do we do the chemotherapy first? Ideally, we want to use the surgery in those patients with an early stage diagnosis because that's the best time to surgically remove the cancer and it is more likely to eradicate it. However, sometimes we do perform surgery on patients who already have a reoccurrence, and this would be called a salvage surgery. So after the initial treatment, the cancer tissue comes back from the original site of initiation. For example, if we had cancer in a particular tissue that we removed, and then 3 years later it comes back from that same site, the cancer returns to the same site, then we can do a second surgery, but that would be considered a salvage surgery. As a general rule, reoccurrence cancer for prognosis is always worse than the original, the first round of the cancer. And surgery can also be palliative, meaning that we already know we cannot use surgery to save the life of the patient, but surgery can help relieve the symptoms. It would help to improve the quality of life until the patient's end of life. For example, if cancer is compressing the spinal cord, so the patient may be having excruciating pain or have certain limitations in the use of their arms and legs. So although at this stage we may not be able to stop the inevitable, but we can remove the tumor so that these symptoms can be controlled or that we can get rid of the symptoms totally. The patient can then enjoy a better quality of life during their final days. So this list is an incomplete list of cancers that may need surgery. It could be head and neck, it could be GI system cancers, it may be in the skeletal muscle or in the bone tissue. One thing that we need to know that for surgery, although intuitively we may think that a very complete surgery will literally take certain tissues out, but it may not be the best or even the most appropriate treatment for some cancers. For example, sometimes the treatment of breast cancer involves a very extensive surgery, and the patient has to have their breast removed in addition to a lot of the muscles in their torso. Even the pec and the lat muscles will be removed. But then after years of observance and study, researchers realized that this type of extensive surgery does not really improve survival rate. So that's why right now treatment of breast cancer is really mainly focused on radiation, and surgery plays a secondary role. Chemotherapy is systemic treatment because in this treatment, medications are given throughout the entire system with IV injection, and it affects the whole body. The hope is that through this treatment, we could eradicate cancer cells, and even including those that might have spread out from the primary site. And similar to surgery, chemotherapy can be used as a primary treatment, or it can be used as an adjuvant treatment to improve a symptom or improve quality of life. So kind of as an alleviation treatment. In terms of classification of all the chemo agents, there are 4 classes. The first one we see here targets DNA during replication. So we know when DNA replicates, the double helix structure needs to unwind, and when the 2 strains are separated partially, that's a vulnerable moment for the chemo agent to function. And once the DNA is disrupted, then obviously the cancer cells cannot go through the normal division and growth anymore. So this is how they are killed. So the second category of chemo agents, they are basically biological compounds designed to interact with a molecule target that leads to uncontrolled proliferation in tumor cells. So we're targeting this molecule that causes the cancer cells to not die. As we mentioned earlier, many cancer cells no longer go through the apoptosis process that the normal cells undergo, so we may want to target this process to make them mortal again. We don't want to have that uncontrolled proliferation. And we can also use hormone therapies for some types of cells. For example, certain cancer cells may get stimulated by certain messenger molecules, and certain hormones may counteract these messengers, eventually suppressing the growth of the cancer cells. Or we can have macromolecules that have a specific target that can regulate the growth of tumor cells or induce a stronger, more efficient immune response to kill the tumor cells. So we may have different chemo agents, and they have a different mechanism to function against the cancer. When we talk about chemotherapy, we cannot afford to ignore the side effects. We mentioned chemotherapy is a systemic therapy, therefore the side effects can affect many tissues and many organs in the systems. This is a list of common side effects due to the fact that chemotherapy works because it has a toxicity effect on those rapidly dividing cells. Our primary target is the cancer cells that are rapidly dividing, but we do have several types of normal cells in the body that also go through rapid division. For example, our bone marrow cells, our GI tract cells in the intestine, they slough off every 72 hours, so we need to have a new line of cells that form that epithelial tissue. So the genes in those cells, they really do need to divide and replicate fast. Also, the cells in our follicles for our hair. So it's very easy to understand that people have some of these common side effects. So they may lose their hair, have a decreased white blood cell count and can also have GI symptoms. And this is because the cells in these systems have a very rapid cell division, and that makes them more vulnerable to the effects of the chemotherapy. Then there are other side effects. For example, it may harm our cardiac function, and in certain cases, it could literally lead to cardiac arrest. It can also affect our neural or kidney tissue. Radiation is different from chemo in that radiation therapy is a localized treatment. It works by delivering some high energy radiation. It could be gamma or X-ray, or it could be a different type of energy. But the effect is that this high energy electrons affect cellular and nuclear material, and hopefully that can disrupt the cancer cell's DNA, and then of course eventually kill the cancer cells. The treatment effect and the toxicity effect of radiation, they are both localized. We really want to determine exactly which area we want to receive this high energy, again, whether it's the gamma or other high energy particles from other sources. So we can deliver the radiation either from outside the body or inside the body. Radiation therapy can be used on its own, or it can be combined with other treatments. We mentioned we could have a surgery first, followed by radiation, or we could have radiation combined with chemotherapy at the same time. It all depends on the type of cells we're trying to target and the stage of the disease, as well as how well the patient can tolerate it. So this lists examples of cancer that are appropriate for radiation treatment. So head and neck cancer, for example, for throat cancer, we can do surgical removal, but we can also do radiation therapy. For many head and neck cancer patients, the effect of radiation therapy is not worse than surgery. So in other words, they are comparable. But obviously, surgery has a lot of side effects. It's more invasive. So right now, a lot of head and neck cancer, for these, surgery is playing a secondary role and radiation is used as the primary treatment. And Hodgkin's disease, so that's a type of lymphoma. And if we think about this, we have lymph nodes all over the body. We cannot realistically surgically remove every single one that is affected. So it's easier for the physician to decide which areas of the body to radiate, and of course those areas could cover the lymph nodes that are affected by the lymphoma. So specific tissues may have better results with radiation therapy. For example, testicular cancer radiation. For testicular cancer, radiation and chemo are really promoted. And also for thyroid cancer, we know that the thyroid is an organ that is really rich in iodine. And because iodine, this is because iodine is the mineral needed to synthesize the thyroid hormone. Therefore, if we use a radioactive iodine isotope, it can congregate inside the thyroid tissue. So this type of radiation is localized or concentrated to the tissue affected by the cancer. So this would be a use of internal source of radiation. Also, women's cervical cancer, the source of radiation could be placed inside the cavity. Again, so it's close to the vicinity of where the cancer originates, and this would spare a lot of tissue damage. You know, if we're comparing it to external radiation, which would penetrate everything on its way until it reached the location. So the more localized we can get it, the less surrounding tissue we risk damaging. So we already mentioned different ways to deliver radiation therapy. So brachytherapy, That's what we talked about in the case of female cervical cancer, where we place the source of radiation inside the body cavity. We can also use radioimmunotherapy, which means that we deliver radiation to a certain tissue through attachment to a monoclonal antibody. So the monoclonal antibody, that's something we develop outside the patient's body that specifically targets a particular type of cancer cell with a particular type of surface marker. So if we think about an antibody with an antigen, the attachment to the monoclonal antibody allows the radiation to have a guided target. It just won't go around hurting other things. It will affect cells with a specific marker only, and in this case, we are targeting cancer cells. And photodynamic therapy targets cancer cells that have a particular chemical and that then produce free radicals and cause the cells to die. So we know free radicals, they destroy molecules and can cause cell death. So the free radicals already cause the damage and radiation. So all of this combined leads to the death of cancer cells. We can also apply a strategy called accelerated fractionation. For any patient who receives radiation therapy, the doctor will prescribe a total dose. And that total dose is divided into different sessions. Usually it's on a daily basis. In a sense, this strategy is similar to maybe if we were to have a prescription and then also want to divide the total daily dose into 3 different deliveries. Depending on the type of cancer we're dealing with, these daily doses could be an equal dose. For example, if they have 4 weeks of radiation, every day the patient receives the same amount of radiation, or we can use the accelerated refractionation. That means at the beginning, we may use a daily dose that is low, and then towards the end, we may increase the single dose each time they receive radiation. At the same time, we may give them radiation twice a day, so that will basically shorten the duration of the radiation therapy. So in certain types of cancer that strategy, the accelerated refractionation, can achieve a better outcome than, say, a daily dose that's distributed evenly. So for the side effects of radiation, remember radiation is localized. So depending on the site of injury, if there's a wound or surgical incision, wound healing may be delayed and many people will experience fatigue. Also, depending on the sites affected, they may have inflammation of the mucus in that area. They may have dysgeusia, xerostomia, especially in the head and neck patients. So they feel that their mouths are dry and nothing tastes the same anymore. Esophageal cancer radiation, for this, the cancer itself could lead to dysphagia, and also the treatment by radiation could lead to rigid tissue at the site of radiation, and that could lead to swallowing difficulties as well. We could have inflammation in the intestine caused by radiation, and it could even lead to tissue damage. So we may have a fistula at the location of the radiation. Particularly if we're talking about the GI tract, since the site of radiation, where the site of radiation in the lumen is, the lumen there may become narrowed because the tissue previously was cancer, but that the cancer was killed and then a scar tissue replaces it. However, the scar tissue is different from the original smooth muscle tissue, and the original tissue, was flexible. It could contract and relax and elongate, unlike the scar tissue. So for severe cases, especially in the GI tract, this could cause malnutrition, malabsorption, and diarrhea. In this case, especially the radiation in the GI tract or anywhere that it's affected, we may have to use parenteral nutrition because with a lot of these GI symptoms and side effects, enteral feeding or oral intake would not be possible for the moment. Other therapies of cancer could include hematopoietic stem cell transplantation. So we can use this strategy to treat specific cancers, for example, leukemia. That's also a type of cancer that, if we think about it, surgery wouldn't be very effective because it occurs in the blood. So what part of the blood circulation can we surgically remove? It's circulating. And we know red blood cells are synthesized in the bone marrow. And if we have these cancer cells, that means our bone marrow is where the cancer cells originate. So we have to get a healthy donor with the stem cells and then go through radiation and kill all the bone marrow cells that are already containing cancer cells, then do the transplant. So hopefully these cells will get planted and there won't be severe rejection, and that will allow the recipient to have a better chance to literally cure the disease. So here's some more information regarding hematopoietic stem cell transplants for both blood-related cancers and other cancers. It was previously more well known as a bone marrow transplant. So these types of stem cells are immature and they can form white blood cells, red blood cells, and platelets. And they are usually found in the bone marrow and also umbilical cords. And some are found in the bloodstream, and these are called peripheral blood stem cells. As I just mentioned, this transplant is used in conjunction with chemo and radiation to kill existing cancer cells and also for immunosuppression to reduce risk of rejection. And of course, we want to avoid graft versus host disease, which involves long-term medical problems, including immunosuppression, organ dysfunction, and infections. So graft versus host is a concern with allogenic transplants where there is a donor source of the stem cells. So the risk of this graft versus host disease is around 30 to 40% when the donor and the recipient are related, and goes up to 60 to 80% when they are not related. Immunotherapy is also very popular. It's currently a very hot area for cancer research because this type of therapy relies on further dissimulation of the immune system so that our cells and antibodies and other molecules involved in immune function can destroy cancer. So obviously this would have much less side effects compared to chemo. We can also utilize certain cytokines, for example, cytokines, they're the messenger molecules and a lot of them are synthesized by white blood cells, for example, interleukin and interferon. And cytokines can mediate a lot of processes. Remember, even inflammation. So these cytokines will regulate an immune response, inflammation, and the generation of blood cells. So all of these therapies could be helpful in treating cancer.